Hi everyone, I am Dr. Wafa Badawi, a senior consultant histopathologist and head of pathology department AKMICH KSA. I'll be talking about sex-cord stromal tumors of the ovary, juvenile granulosa cell tumor. General background. Juvenile granulosa cell tumor is a six-cord stromal tumor composed of primitive appearing granulosa cells with follicular and solid growth patterns. It comprises 5% to 15% of granulosa cell tumors. Juvenile granulosa cell tumor represents 10% of ovarian tumors in women. Most patients are young. A total of 97% of juvenile granulosa cell tumors occur in patients younger than 30 years. These tumors frequently produce estrogens and are typically associated with isosexual pseudoprecocity in most prepubertal patients. Juvenile granulosa cell tumors presenting after puberty may be detected secondary to abdominal swelling, pain, pelvic mass, or menstrual irregularities. A few tumors have been found in association with Olea disease in chondromatosis, Maffucci syndrome, multiple enchondromas, hemangiomas, and other mesenchymal tumors. Beckwith-Wiedemann syndrome. Unlike its adult counterpart, juvenile granulosa cell tumor is not commonly associated with FOXL2 gene mutations. Gross appearance. Approximately 98% of juvenile granulosa cell tumors are unilateral and range from 2.5 cm to 32, average 12.5 cm in maximum. The gross appearance is similar to that of other granulosa cell tumor, ranging from solid and cystic, approximately 50%, to predominantly solid. The solid areas frequently have a nodular, rubbery, tan to yellow cut surface, whereas the cyst contains serous or serosanguineous fluid. Hemorrhage and necrosis may be seen. Microscopic features. Juvenile granulosa cell tumor shows different growth patterns, including diffuse growth pattern, lobular growth pattern with follicle-like spaces, nodular growth pattern. These tumors are composed of proliferating granulosa cells set in a myxoid or edematous background. The nodules may become extensively hyalinized. Follicle-like structures of varying sizes and shapes are a common feature. They are lined and separated by a variable thickened polyhedral granulosa cell layer with adjacent, less well-organized aggregates of cells with pale cytoplasm and rounded, immature, non-grooved nuclei. Microfollicles and macrofollicles formation contain eosinophilic secretions. These images show longitudinally sectioned follicles. They are lined internally by multiple layers of cells resembling granulosous cells. The outer layers of cells resemble thicker cells of normal Graafian follicle, and they merge with the surrounding stroma. The tumor cells of juvenile granulosous cell tumor have round to oval and hyperchromatic nuclei with occasional nucleoli. Note the lack of grooves. The cells have moderate to abundant quantities of pale eosinophilic or amphophilic cytoplasm. Mitotic activity is commonly increased. The granulosous cells are generally larger than those seen in adult granulosous cell tumor. Mild to moderate cytologic atypia is present and does not affect the prognosis. Focally marked nuclear atypicality is present in this photo. Large bizarre nuclei and a single follicle are present in this photo. Bizarre and atypical nuclei are rarely present. In this photo, the follicle-like spaces are lined by cells with moderate amounts of cytoplasm and show nuclear atypia and prominent nucleoli. In this photo, many follicles are lined by cells with atypical Hoppe nuclei, simulating tubulocystic clear cell carcinoma. Immunohistochemistry. Juvenile granulosous cell tumor shows a similar immunohistochemical reaction to that of adult granulosous cell tumors. It shows FOXL2. It is a transcription factor. It shows nuclear positivity, carrotinin, nuclear and cytoplasmic immunoreactivity, SF1, strong nuclear immunoreactivity, inhibin. It is variable, ranging from strong, as seen here, to weak to absent, 20% of cases. Smooth muscle actin, scattered cells displaying cytoplasmic staining. Prognosis and therapy. Stage is the most important prognostic parameter in these tumors. Nearly all patients with stage 1A tumors remain free of tumor, whereas those who present with advanced stage tumors generally die of disease. Nuclear atypia and mitotic activity have not been found to correlate with prognosis. In contrast to the late recurrences of adult granulosous cell tumors, recurrences of juvenile granulosous cell tumors most frequently occur within 3 years of presentation. These are the references. Thank you.